Okay, welcome guests. It's a pleasure to introduce today's speaker of the webinar, which is Savino Sciascia. He is assistant professor at the Division of Nephrology and Dialysis at the San Giovanni Bosco Hospital in Torino, and he has a special interest in lupus nephritis, lupus in general, and in TMA. And today's webinar will be on TMA and antiphospholipid syndrome. We are very pleased to have Savino Sciascia again. And Savino, please start your presentation.
Thank you, Jack, and thank you, the OLARC network, to arrange this meeting and to give me the opportunity to share the experience of our center here in Giovanni Bosco, Torino, when dealing with a very fascinating disease, such as the antiphospholipid syndrome, from a very specific point of view, which is the relationship between this disease and thrombotic microangiopathy. So here with a little bit of the agenda, and I want to start to create a common ground on the definition of this syndrome. This syndrome is relatively recently described, probably when the first description was when Professor Graham Hughes in London in 1983 had this very nice intuition. He was a worldwide, and he still is an expert in lupus, and he has this intuition of identifying a subset of lupus patients with a higher rate of thrombosis and pregnancy morbidity, and he observed that those patients were more frequently found positive for a family of antibodies that at that time were defined as antiphospholipid antibodies. So the association of thrombosis and pregnancy morbidity in the context of persistently positive antiphospholipid antibodies since then defined the syndrome. Originally described in patients with lupus, we all know that now the syndrome can independently exist, and since then we are now able to describe three different variants of the syndrome. First of all, the so-called thrombotic APS, that has a very particular feature. In fact, it's one of the few thrombophilic diseases in which both venous and arterial can be affected. We also have the obstetric form of the syndrome, in which pregnancy morbidity, either with early miscarriages, fetal death, or premature birth, can be associated. Of the most severe, even though the most rare manifestation of the syndrome, which is the catastrophic APS. It's a rare condition, can be life-threatening, and this is characterized with a simultaneous occurrence of thrombosis in different systems. And in these very cases, the kidney is almost in all the cases involved. However, when saying this, one consideration is noteworthy. Thrombosis, pregnancy morbidity are very frequent events in everyday clinical practice. Still, antiphospholipid syndrome might be considered a rare disease because it's crucial to identify the role in this clinical setting of the antiphospholipid antibodies. What are these antibodies? These antibodies are a heterogeneous group of antibodies directed against phospholipid binding protein. The current classification criteria identify three of these antibodies, and at least one of those has to be persistently positive when thinking about this syndrome. The two early described were the anticardiolipin antibodies and a coagulation assay named at that time as lupus anticoagulant. More recent, a new antibody specificity has been described, the anti-beta-2 glycoprotein 1, which is a new antibody specificity that improves the accuracy in diagnosis of disease, but also helps to identify the beta-2 GP1 as the pathogenic antigen of this syndrome. For those of the audience that are more early in their career, it's worth mentioning some historical aspect of the description of the lupus anticoagulant, which is a bad name for an old test. In fact, lupus anticoagulant is not specific for lupus at all. And despite the name anticoagulant, indeed, this test, which is a coagulation assay that we can define as a modification of the activated thromboplastin partial time, so a modification of the coagulation time, if tested positive, is associated with an increased risk of thrombosis. As I said, this test is a modification of the ATPT in which we use a different activator to induce coagulation in vitro. One of the most used activators is the Russell Viper venom time, in which we are able to observe in vitro a prolongation of the coagulation assay. And this is due to the interaction between the antibodies and the coagulation system. So it's worth mentioning that we have in vitro a prolongation of the coagulation assay, which is paradoxically associated in vivo with a prothrombotic status. I previously mentioned that APS is considered a rare disease, but what do we know about the epidemiology of this syndrome? Well, as I say, thrombosis are frequent in everyday clinical practice. Pregnancy morbidity can be frequent as well. And most of the data that we have when thinking about syndrome are from cohort of patients with clinical manifestation that have been then tested for APL. And now we know that up to 9% of patients with pregnancy loss might be positive for at least one of the previously named antibodies, up to 14% of people with stroke, 11% of patients with myocardial infarction, and up to 10% of patients with deep vein thrombosis. So even if the disease per se might be rare, the presence of APL positivity should be taken into account when dealing with any thrombotic event. And when referring to traditional epidemiology, there are data from the Mayo Clinic, but also confirmed from our registry in the northwest of Italy for rare disease led by Dario Roccatello, in which we confirm that the prevalence of this syndrome in both the American and Italian court ranged between 17 to up to 50 patients over 100,000 of subjects. So this is the general introduction, but from a clinical point of view, what we have to remember about this syndrome. First of all, we have to remember that this is probably the most common cause of acquired thrombophilia, and again, the unicity of this syndrome is that can affect both venous and arterial events, can be responsible to up to 20% of recurrent miscarriages, 1 out of 5 of stroke, especially in young people, and this is important for the management of this patient, and especially from a nephrology perspective, we have to remember that up to 20 or 30% of our SLE patients might be positive for antiphospholipid antibodies, yet not having the full-blown syndrome. And finally, and this is very important from a clinical point of view, thrombosis can happen at any vessel of any size. And this is the key point moving to the focus of this talk together. Indeed, from the renal artery to the renal vein up to the glomerular level, each part of the kidney vasculature can be affected by thrombotic events associated with the presence of antiphospholipid antibodies. So we have 3 potential scenarios in this way. We can have kidney manifestation in patients with an already known full-blown APS. We can have patients with antiphospholipid antibodies positivity, yet not having the full-blown syndrome, which means APL positive, but no previous stories of thrombosis, nor previous stories of pregnancy morbidity. Or the other side of the coin, we can be attending a patient with, for instance, a thrombotic microangiopathy, either with acute or chronic features, and some of them might present, if tested, with positivity for antiphospholipid antibodies. These 3 scenarios might cover the spectrum of the renal manifestation in patients with antiphospholipid antibodies. And this is just to trigger the discussion. We have said that APS is a rare disease, but on the other side, that APL positivity might be not that rare. So imagine to take a cohort of 1,000 patients with APS. How many of those would you expect to have a renal involvement that can be linked with the presence of APL? And this is the first full question of this talk.
Okay, the audience is now asked to answer the question. Please select one of the answer possibilities. We will take 5 more seconds. Okay, we should stop. So these are the answers that are given. 15% tells you more than 5%, 32% less than 5, 36 about 10, and 70% about 21. Sabino.
Okay, and let's see, I mean, as usual, in rare disease, the answer is never easy, and I can fully understand why we are all sharing a different opinion. But all in all, we can go back to, again, when we don't know the answer, go back to the data and with people who describe this disease at the very beginning. And this is probably the first inception cohort started by the fathers and mothers of this disease, including Ricard Cervera, Graham Hughes per se, in which first including and then following for up to 10 years a cohort of patients of 1,000 APS, they assessed that the prevalence of renal involvement directly attributable to APL was as high as 2.7%, so roughly at 3%. So it's not the most common clinical manifestation, yet can be very challenging when presenting. In fact, when following up those 1,000 patients for over 10 years, and this is the same group with the first publication in 2002 and the second one 10 years later, they observed that during the follow-up, 5 patients developed, despite the ongoing therapy, new glomerular thrombosis. And among those in which APS was associated with SLE were the most prevalent group. And this is another point to keep in mind, especially later for this talk, when we will be dealing with this problem. Another important point of that study, again, following 1,000 patients with APS for over 10 years, is that among those patients who experienced a fatal event, and the fatality rate was around 10% over 10 years, all the patients with renal event were those with a poor prognosis. So this is, again, another take-home message. Yes, renal involvement in APS is rare, but when happens, it requires attention because maybe one of those events directly impacting on the prognosis of our patient. Moving from the definition to the more clinical and diagnostic aspect, I want to list with you some of the most frequent clinical presentation of kidney manifestation within the spectrum of APS. We have renal artery stenosis and thrombosis, renal vein thrombosis, renal infarction, the so-called IPS nephropathy, on which we will spend more a little bit, and the catastrophic form that, as we mentioned at the beginning, is usually represented by a microvascular events that often include the kidney with feature of APS nephropathy. Some historical data, and again, this data comes from the group who firstly described this syndrome. They firstly pointed out an association between renal artery stenosis, the presence of antiphospholipid antibodies, and hypertension. And what they did, and I want to point out from both historical and anecdotal information from this point of view, they compared 3 groups. The first group of patients with either APL or APS with uncontrolled hypertension, and they compare those patients with a group of patients with uncontrolled hypertension without APL, and a third group of patients with APL positivity but no other clinical manifestation. And what they found at that time? They found that up to 26% of patients in the first group, which means patients with APS or APL with uncontrolled hypertension, were more frequent in the context of APL positivity. And when they keep telling the story of following those patients, this is what they found. They found imaging proof of magnetic resonance angiography showing renal artery stenosis in a patient with APS, and this was confirmed after angiography. Again, at that time, prospective data were still missing in this syndrome, and they retrospectively collected from the same group of patients those who receive anticoagulation for at least 1 year. So data from the same group, and Shiri Sangol was the fellow leading the study at that time. They found that those patients in which the anticoagulation was maintained with an INR around 3, those patients were those in which the blood pressure control was achieved more easily. Again, this is anecdotal results. This was part of the historical data of this syndrome, but yet, as a take-home message, this disease is rare, and again, renal artery, either stenosis or thrombosis, can affect any vessel in this context. And this is picture taken from the studies again, showing a angiogram 2002 and 2004 with signs of recanalization. Now we move together to probably the core topic of our chat here, on the so-called APS nephropathy, also referred sometimes as APL-associated nephropathy. When referring to the current classification criteria, this is the definition that I want to share with you. So this is a thrombotic nephrangiopathy process involving both arterioles and glomerular capillaries, and or at least one of the following: fibrosymptomal hyperplasia involving organized thrombin with or without sign of recanalization, fibrous or fibrocellular occlusion of arteries and arterioles, focal cortical atrophy, or tubular thyroidization, which is large zone of atrophic tubules containing eosinophilic cast. So in the idea of the people who first described the classification criteria in 2006, this was what we can refer as APS nephropathy. There is a but. The use of and or and the inclusion of one or more of the following has led over the years of a huge heterogeneity in what has been referred as APS nephropathy in the clinical course that we have so far available. So I want to state that the criteria and the people who described back in the 2006 the criteria for the syndrome is very clear in their mind what can be put under the umbrella of the APS nephropathy. However, the use of a very broad generation, as often occur in the context of classification criteria, has led over the year or possible misinterpretation of these criteria. So don't be surprised when going through the literature on this topic that there is still a huge amount of heterogeneity when referred to this definition, APS nephropathy and APL-associated nephropathy. So in case of doubt, go back to the original publication and look the inclusion criteria of that specific studies and what the authors were referring to. And again, in order to keep the educational purpose of this talk, and I'm referring mainly to our young colleagues in this context, I want to stress that the presence of vasculitis, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, but also malignant hypertension and other causes of chronic related ischemia are all exclusion criteria for the APS nephropathy. So think about as APL-related nephropathy as a differential diagnosis of the previously mentioned condition, But, and this is an important point, APS nephropathy and APL-associated nephropathy can coexist with lupus. And it's always important to differentiate in terms of renal histology what is related to lupus nephritis and what is related to microangiopathy involvement in APS, because this might change the prognosis and the management of our patient. And we will deal with this in a while. I want just to share now with you some picture from our cohort of what we consider APS nephropathy. And this is, for instance, an intracapillary thrombi in the glomerulus in which the afferent arteriole is occluded. And you can see that marked by the arrow. This is another example in which we have fibrinode necrosis and mucinoid intimal edema with at the level of the intima arteriole, again the red arrow there, and the interstitium is edematosus. But other picture in which you can find a thrombi occluding peritubular capillaries with the interstitial edema, hemorrhage, acute tubular injury might be also present, especially in the context of acute ischemic injury. Keep going with a different staining. We go to the picture show you a large intravascular thrombus at the level of the vascular pole using here a trichrome staining. And when referring to immunofluorescence, usually as expected, we have a positive staining for fibrinogen in the level of the thrombus. If you are lucky to have also electronic microscopy to explore those patients, we might find similar feature of those that I'm sharing with you at this moment, like in the panel named F, we have fibrin occludes the capillary lumen with the endothelial cells losing the fenestration and podocytes show the food process effacement. Or on the other side, we find a double contour without, and this is again important, interposition of electron-dense immunocomplex. And this is something that you have to keep in mind when thinking about the syndrome. We don't have, at least at this level of knowledge of this syndrome, interposition of electron-dense material seen in this patient. I'll show you some picture of renal biopsy from our cohort, but we have to keep in mind that this is often a question that might arise, especially when thinking that this patient might be referred from hematological point of view, immunologist of internal medicine. These are on one side patients with a prothrombotic status by definition, and on the other side, those patients are a higher risk of bleeding because of the ongoing anticoagulation or because the APS may be also often associated with a low level of platelets. So is it safe to perform kidney biopsy in this patient? The answer, this is our experience, is yes, if we perform kidney biopsy, even in a context of an outpatient setting, in a very protocolized way, with a very strictly managed bridging therapy, moving from the ongoing anticoagulation to the use of heparin, assessing both bleeding and thrombotic risk tailored for each patient, and managing when ongoing the antiaggregation, moving from conventional antiaggregation to other agent with a lower half-life. So despite those patients might be challenged, yes, overall, when the kidney involvement is suspected, kidney biopsy is still the gold standard to confirm our hypothesis. Now I want to move to probably the most challenging aspect of this topic is when glomerular mucothrombosis or TMA happen in a patient with lupus nephritis and antiphospholipid antibodies. And I want to share one of the cases who triggered my interest in this field, because as very often happens, is the story of one very patient that might trigger a new line of research. So I want to share with you the story of Lisa. Lisa is, at the time of the assessment, was a 24 years old young woman. She was diagnosed with SLE when she was 14 on the basis of ANA positivity, anti-Smith. So her laboratory profile was in line with the diagnosis. She has a skin rash at that time, photosensitivity, arthralgia, recurrent apoptosis, and the full-blown positivity for antiphospholipid antibodies, so glucose anticoagulant, anticardiolipin antibodies, and anti-beta-2 GP1 positivity. So mainly a mucocutaneous and articular SLE that has been managed with hydroxychloroquine, low dose of steroid, and azathioprine for over 10 years. And low dose aspirin was added at the time when she was managed in the pediatric ward to counterbalance the thrombotic risk due to the presence of antiphospholipid antibodies. So to introduce the context in this case, we are in one of those scenarios that I want to introduce since the very beginning of this chart. So this is probably where the most gray area exists. So what to do in the kidney, in managing the kidney manifestation of a patient with APL, but not a full-blown APS. What we know. So let's again, when we don't know, let's go back to previous study and let's see what the godfather and godmothers of this disease have said before us. And this study is from Gabriella Moroni showing that the presence of antiphospholipid antibodies over the year is a negative prognostic factor for kidney survival in patients with lupus nephritis. And again, we also know, and this is a study dated back 2007, that APS nephropathy and lupus nephritis can indeed coexist. And patients with both conditions are more likely to have hypertension, heavy proteinuria, and a faster progression to end-stage kidney disease. So going back to the story of Lisa, this is what we know at that time when attending her. She was moved from the pediatric ward to our attention, and she presented us with a nephrotic range proteinuria, a newly diagnosed arterial hypertension, and these are her blood. So hemoglobin 11, platelets and white blood cell overall were fine. We have an increase of creatinine up to 1.4. The proteinuria was of nephrotic range. We have active urine sediment, low C3 and C4 as expected in an active lupus, positive anti-DNA, and an increased ESR with normal CRP, which is again what we usually expect in the context of an active connective tissue disease. A renal ultrasound that at that time was completely normal. So of course, we went through the kidney biopsy, and this is what we found. We found a diffuse class 4 global lupus nephritis with a full house immunofluorescence, and so far the case has nothing striking. So this is a very traditional, conventional case of lupus nephritis. When thinking about the management of this patient, she was a young patient, white background. In order to preserve her fertility, probably induction therapy and management with mycophenolate could have been the first choice. But the story of Lisa was characterized with a big but. We didn't find only class 4 lupus nephritis in her, but you also find these features. We found a full-blown thrombotic microangiopathy with fibrinoid necrosis of the preglomerular arterioles, and this picture are very nice, and even for those of you who are not familiar to look directly to the pathology, this is very clear what we are looking for. We found intima hyperplasia and the so-called onion skin lesion and fibrinoid insudation. And so the point at this, the challenge of our management was, we have on one side class 4 lupus nephritis, and we know what to do with this patient, young patient, conventional lupus patient. On the other side, full-blown thrombotic microangiopathy. What to do? And now, again, the question is up to you. What would you do? would you change your therapeutic approach, knowing that she has also a full-blown TMA in the context of lupus nephritis? And here, the poll is open.
We have 5 more seconds. Okay. So 86% would change the treatment approach.
Okay, perfect. So we agree that we will do something else. And the point is that if we follow our process of thought, so we know that Lisa was positive for antiphospholipid antibodies. She developed with that feature of thrombosis, even though they were at the microvascular level, which means, should we consider antithrombotic, generally speaking, agents in her? And in this case, would you just keep going with an immunosuppressant? Should we add antiaggregants, heparin, VK antagonist, direct oral anticoagulant? And again, now, up to you.
Okay, you can vote again with 5 answer possibilities and select one. Okay, we will take 5 more seconds and then we should stop. Okay, so most of the respondents would change the treatment and add something to treat the coagulation status, but there is a wide range. So 37% would add aspirin or something like that, 21% would give a heparin, 24% would give a vitamin K antagonist, and 10% would add DOACs. 8% would not do anything else than give immunosuppressants.
Perfect. So very heterogeneous results, and I completely agree with you, especially at that time. We still don't know. And that was the gray area that allows me to move from what we know about the therapeutic option of this situation, especially when the two situations exist, thrombotic microangiopathy and lupus nephritis. So we have seen that even here in the context of all people interested in this disease, there is still a heterogeneity of how we manage this condition. Let's start and try to create a common ground of what we know. First, we know that TMA per se is a poor prognostic factor when managing lupus nephritis. And this is just one recent paper among others showing that the rate of remission between patients with lupus nephritis with and without TMA is roughly 2/3. We have to up of 50% of patients with lupus nephritis who did not achieve remission at 1 year from the induction therapy. And this is something that we don't see anymore in our patients with lupus nephritis without thrombotic microangiopathy. What else we know? We know that thrombotic microangiopathy in patients with lupus nephritis is associated with the presence of antiphospholipid antibodies. And that these are data from R, for instance, 2014, APS diagnosis, so the full manifestation of the syndrome, but also just the positivity for lupus anticoagulant, or even more than one antibody's positivity. All these conditions are associated with the presence of thrombotic microangiopathy in the context of lupus nephritis. And finally, again, to quote the data of Gabriella Moroni, We know that the APL positivity is a poor prognostic factor in our patient with lupus nephritis. So again, what we have to do with LISA? We have on one side the immunosuppression, which is centered on the SLE-related, so immunocomplex mediated process. On the other side, we might be prone to start anticoagulation because of the underlying antiphospholipid antibodies related problem. So we split among all the people interested in attending this chat among different options. The answer, as I say, is that we still don't know. Should we do something? Antiaggregant, anticoagulation? And this is a suggestion for, again, those of you who are younger attending this chat. When there is no answer, that is a perfect pathway for research. When the level of evidence is still poor from B and below, when there are no randomized clinical trials, when the level of the agreement, even between experts, is low, that is a perfect pathway for research. And this is exactly what I wanted to start and share with you, is that being that at the time, 2015 and 16, young girl as Lisa did not have a proper reply, we decided to take occasion of that story to create an international study in order to assess the clinical outcome and response of antithrombotic treatment in general in patients like Lisa with both biopsy-proven lupus nephritis and thrombotic microangiopathy. So we ran an international study, as I previously said, under the umbrella of the International Society of Thrombosis and Hemostasis. 3 different centers were included: the Giovanni Bosco Hospital here in Torino, the Lupus Unit London in UK, and the San Francisco Lupus Unit at UCSF. We collect data of biopsy-proven lupus nephritis and TMA project patient. We collect antiphospholipid antibodies profile, their therapy, the outcome, and as a peculiarity of this project, we were very strict with the histological inclusion criteria when referred to the TMA lesion. And we asked to the pathology to rearrange their diagnosis according to a pre-structured layout in order to have all the information that we have and to stress the difference between acute and chronic TMA lesion. The course that we end up with was 97 patients, or patients like Lisa. The age was, as expected, young women, as we know that this is the typical epidemiology of lupus. And when referring to the clinical presentation, roughly 40% of them have nephrotic syndrome, 20% nephritic syndrome presentation, and 40% asymptomatic urine abnormalities. From the lupus perspectives, the majority of them is class 4 lupus nephritis. From the TMA, they were 50-50% between acute and chronic. And for the treatment, most of them received mycophenolate, followed by cyclophosphamide, and 6% other regimen, mainly including rituximab. How they behave, which was the clinical response. Not surprisingly, our clinical response, or the observed clinical response, was the same that which we have in the literature. So roughly 40% of the patients were non-responders, regardless the induction and maintenance therapy that it was used. And complete renal response, when assessed by KDIGO outcome, was not higher than 38%. But what was interesting, that roughly 60% of those patients were APL positive, and 37 of those, which is about 40% of the patients, received vitamin K antagonist or heparis according to the treating physician decision. What we found, that in those patients receiving anticoagulation, the rate of response were higher, as high as 60%, including both partial and complete response, when compared to no higher than 40% in patients with lupus nephritis, thrombotic microangiopathy, not receiving anticoagulation in the context of APL positivity. So what we learned from this experience? we learned that poor prognostic factors that were associated with non-renal response in this patient were strongly anti-DNA positivity, but also APL positivity and the presence of chronic features of DNA. On the other side, we observed that the presence of acute lesion, especially when treated with vitamin K antagonists or heparin, were associated with a better prognosis, even after adjusting for the type of immunosuppressant therapy that patients were receiving and for their lupus nephritis class. So the take-home message of this experience is that indeed the presence of APL and chronic features of DNA are associated with a poor clinical outcome in patients with lupus nephritis. And with the current level of knowledge, at least in patients with APL, the use of anticoagulation might appear productive, especially in the setting of acute TMA. So moving from what we have done, I want to spend the last couple of minutes or no more of your time in identifying from where we have been to where we are going. And these are the future perspectives. The two main pillars of the future research is to move forward in the identification of new pathogenic mechanisms, and secondly, to find therapy for this disease beyond anticoagulation. Because if the antiphospholipid is the trigger of the disease, this is probably what we have to target in order not just to treat, but ideally to cure this condition. This is probably the only cartoon that I want to share with you in terms of pathogenesis. I initially said that the beta-2 glycoprotein is the antigen that is now considered the core of the pathogenesis of this syndrome. It's usually circulating in the bloodstream in a roll form, what is known as sushi domain, then becomes spread out in a J shape when these molecules link the phospholipid antibodies. The domain 1 is just one part of this molecule, that it is the part of the molecule that stays in the bloodstream, and it is probably the part of the molecule that is targeted directly by the antibodies. So the current knowledge of the disease is that probably among all the anti-beta-2 GP1 antibodies, those identifying only the domain 1 are those truly pathogenic. And so probably this is what we have to look for. This is known in thrombosis, this is known in pregnancy morbidity, and this is what we show also in our cohort of patients with lupus nephritis and thrombotic microangiopathy, showing that among all the spectrum of antiphospholipid antibodies, those identifying this new antigen specificity, the anti-beta-2 GP1 domain 1, are those with a better accuracy in terms of sensitivity and specificity to identify the risk of thrombotic microangiopathy. And this is histological proven that when using the monoclonal antibodies on renal stain, the domain 1 was able to stain the endothelium level. Of course, this is just preliminary results, but show that this might be one of the directions that we should look at when thinking of what to target in this syndrome. Because the idea is that we are slowly moving from the idea that antiphospholipid antibodies are only thrombosis who requires anticoagulation to a growing body of evidence that probably the complement is involved, leading to the thrombotic microangiopathy, but also other pathways can be, for instance, mTOR dependent, leading to a more vasculopathy kind of disease. And of course, if we follow this tray of thoughts, probably the future option for treating this condition might go beyond thrombosis, because with thrombosis, probably we just antithrombotic management, because probably with antithrombotic management, we cover just one of the pathways that are responsible for this disease. But probably this might open new perspective when targeting the complement in the setting of microangiopathy, or eventually mTOR inhibitors. And there are only anecdotal experience in this time when thinking about APL-related vasculopathy. And probably what was called in the past as APS nephropathy is a miscellaneous group of all these three condition mix that we have probably learned how to segregate in different subsets. And this is the last idea that I want to leave you with, is that probably APS nephropathy is much more complex of what we have known so far. Is the crosstalk between primary, secondary, which means lupus, but also catastrophic event, in which thrombotic microangiopathy is only one of the possible clinical scenarios. And with this, I hope you enjoyed this chat, at least as I enjoyed, and I thank you all for the attention.
Okay, Savino, thank you very much for this presentation. I've seen many questions coming by, so I think you will need some time to answer some of them. First question is about which precautions should be taken in a child with antiphospholipid antibodies before doing a biopsy. This patient has a prolonged APTT due to probably the lupus anticoagulant, maybe. But the question is whether this patient should be given fresh frozen plasma or IV methylprednisolone before doing the biopsy.
So thanks for the question, because it allows me to stress one concept, especially for the paradox of lupus anticoagulant. Lupus anticoagulant, despite the name is a wrong name, is not associated with a bleeding risk. So even though we see a prolonged IPTT and we see a lupus anticoagulant positivity, indeed, those patients are not more prone to bleed per se, but they have a prothrombotic status. So there is no risk, if there is no ongoing therapy, then the intrinsic risk of those patients with lupus anticoagulant and prolonged IPTT is much more on the thrombotic status rather than on the bleeding. So there is no need to correct the bleeding disorder, because just this is a laboratory way that we assess the interference between antiphospholipid antibodies and the coagulation system.
Thank you. Next question, and I'm not sure whether I understand it, but what is your experience with the use of aspirin and comparable agents in the presence of severe hypertension in patients with antiphospholipid antibodies? And maybe we could extend this question to whether you think that in the series you showed that, let's say, vitamin K antagonist and heparin were maybe improving outcome in patients with lupus and TMA. There is no data on aspirin, I think, at least you didn't show. So what is your thought about aspirin use in patients with antiphospholipid antibodies?
So as a general statement, the idea of primary thromboprophylaxis in patients with APL and no other underlying disease should be considered into a patient-to-patient approach. Usually the likelihood of being more prone to give an antiaggregant is related to the presence of additional cardiovascular risk factor. So we have to think that until we were not able to remove the antibodies, what we have to counterbalance is the prothrombotic risk. So this is a general statement in terms, if you think of adding aspirin to control the cardiovascular risk, this is a way to consider. It's much easier, the answer, when we think in a patient with lupus and antiphospholipid antibodies, in which the use of aspirin should be recommended unless contraindicated for any reason. When mentioning the cohort, and this is again the anecdotal cohort of Asheri Sangol, David De Cruz, and Hughes, of the link between anticoagulation, renal stenosis, and hypertension, I think that the answer is not yet written in the stone. I mentioned that these were small numbers, 23 cases, and of course I don't think that the anticoagulation should be started per se to control the hypertension. The key message, I think, is to think about the presence of antiphospholipid antibodies and to study the renal arteries in those patients who have been previously tested for antiphospholipid antibodies rather than the other way around.
Okay, maybe I can try to set a question more specifically. So if you have a patient with lupus nephritis, no TMA in the biopsy, but the patient has been tested for antiphospholipid antibodies and the antibodies are positive, would you give that patient aspirin or comparable drug?
If there are no thrombotic events before, so just primary thromboprophylaxis in patients with lupus and APL is recommended. And now we have like more as it is hydroxychloroquine, because especially the association of aspirin and thrombotic, and these are data, from instance, from Maria Tectonidou from Greece in long-term course, that the risk of cardiovascular event beyond the prognosis of the renal prognosis is much better in patients receiving antiaggregant when compared to those not receiving. So probably I would be prone, especially in patients with double or triple positivity, no previous event, and lupus nephritis, to give antiaggregant.
Okay, and then if you have the same patient, sorry, if you have the same patient
beyond the kidney outcome.
Then you have the same patient, lupus nephritis, not being treated with anticoagulant or aspirin, antiphospholipid antibodies, and you see TMA in the kidney biopsy, then you would suggest not staying or not giving aspirin, but going for the vitamin K or the heparin?
Again, we don't have prospective data there, but at least the retrospective data that we have so far in those 97 patients show that, especially in case of acute features of TMA, seems that was a signal for a better response in terms of clinical in renal response in patients receiving anticoagulation. Again, those data are not prospective, it's not randomized, but the signal in that cohort was there. This is what we have to do, a randomized control trial to answer that.
Yes, but in your practice, what would you do?
This is what we so far have been considering. So if we have features of a mainly acute patient with lupus nephritis and a strongly persistent positive, at least a try with anticoagulation, starting from heparin, and then eventually reassessing for the need of prolonged vitamin K antagonist has been considered as in our practice.
And do you take into account the number of tests that are positive? So do you make a difference between only anticoagulopin or triple positive?
Yes, this is another $1 million question, but usually the higher the number and higher the titer, higher is the likelihood to confirm and move to anticoagulation. So if we have just low titer or not persistent positivity for one of the tests, probably the indication for anticoagulation is not as strong. But if we have a patient with persistent positive 2 or 3 tests, eventually with higher titers, and IgG more than IgM, the indication for the use of anticoagulation gets stronger.
Okay. In your experience, is it easy for the pathologist to differentiate between the acute and chronic features of TMA?
It's definitely not easy, and this is a thing that the features, but that we all face. But on the other side, I mean, the rarity of this case allows that if you have any doubt, always the multidisciplinary approach, so talk to the pathologist, helps. So I think that the key, and what I can say, I'm lucky enough to work in a group in which this is part of our routine base. So if I have any doubt, directly liaising with the pathologist, make the strategies clear. But of course, there is a lot of gray area between acute and chronic. But at least the prevalence, it sounds more an acute feature rather than more of a chronic one, might guide the judgment.
Okay. Then another question is about patients with end-stage kidney disease, not lupus, who has been tested for antiphospholipid antibodies and is double or triple positive, and that patient has probably no signs of antiphospholipid syndrome yet, but is considered for kidney transplantation. Would you suggest any special anticoagulation procedures when you go to this kidney transplant? So would you, prophylactically or postoperatively do something more than the usual standard probably low molecular weight heparin?
No, usually it's not a matter of, this is another very good question and things that happen in the routine practice, and we receive some referral from this problem. Usually the answer is not per se in terms of the intensity of the anticoagulation, but more on the length of the anticoagulation, because we have seen that any procedure, any surgical procedure increase the risk of thrombotic event beyond the kidney, by generally speaking, in patients with APL, beyond the usual risk of surgery. So the indication is usually just to have a longer thromboprophylactic rather than a more intensive one.
Okay. Another question is about not lupus, but the antiphospholipid syndrome. Would you agree that at the moment there is no, or there's not sufficient evidence to promote the use of DOACs?
Other good point. Yes, we don't have at this point. We have an initial trial that was suggesting some positive results, but this trial led by Anna Cohen used surrogate biomarkers. The second trial led by Vittorio Pengo was prematurely stopped because a higher incidence of arterial event in those patients receiving rivaroxaban. So at this point, there is no strong indication for the use of DOAC routinely, especially in patients with previous arterial event and especially in patients with triple positivity.
Okay. Then another question is about when a patient with positive antiphospholipid syndrome is going to receive a kidney transplant. Would you recommend prophylactic eculizumab?
So far, there are no data. So there are, at least at the best of my knowledge, 2 case reports over in this setting, over probably less than 12 in which eculizumab has been used overall to treat antiphospholipid antibodies. So too little to have a strong opinion.
Yeah. And would you see any role for plasmapheresis in a patient with lupus nephritis with concurrent thrombotic microangiopathy?
Other good question is not solid data, and when compared to other contexts of TMA, this is one of which plasmapheresis has been less used, especially in the recent year. Plasmapheresis in APS so far has been used in complicated obstetric and complicated pregnancy morbidity situation, but the experience in APS, even in the larger insertion core that we have so far, is very anecdotal. So again, the indication is not strong and probably is not the APS per se supporting that indication.
Yeah. Then a question about the role of complement in this, let's say, antiphospholipid antibody-mediated TMA. Are there any studies which you would suggest that you can do to suggest or indicate that it's complement-mediated, and should that lead to a change in therapy?
Okay, we may need probably another 1 hour talk to reply to the complement role in the.
Well, this is the last question I will allow.
But yes, there is complement activation data coming from the best of what we know is that was when studying placenta level, in which we saw a complement deposition in women with APS. Then data from Milan from Professor Meroni showing that complement indeed is also present in the thrombi of large vessel, both in a mouse and in vivo model. For thrombotic microangiopathy, we are working on that, but it's very likely that is a complement-mediated activation, that's something between what we expect in terms of other thrombotic microangiopathy levels. So the idea is that yes, on the experimental model, but probably is too little information so far to consider complement directly as a therapeutical target in the routine way. As I previously said, there are probably less than 10 cases reported so far.
Okay. Well, I think the hour has been made. I thank the audience. We had a large audience today, so you are, your talk is very well received. I thank you, Savino, for your presentation. Hope to see you soon. I thank the audience, and I remind you that in the coming time there will be new webinars. So please keep attention to your email, and here you have a list. The coming webinars about atypical hemolytic uremic syndrome, June 1st by Marina Norris. Then a topic June 15 on Dense disease. And then June 29, Jürgen Floge will give an update on the new KDIGO guidelines. So thank you very much, and say bye-bye. Bye-bye.
Bye. Bye-bye.
Bye.